I'm going to just discuss a little bit about what we do as a part of our treatment with bipolar disorder. And bipolar disorder is one of the major challenges we face in psychiatry. Often it is really difficult to diagnose someone with bipolar disorder. So you really need to have a very thorough history. And I emphasize this because a lot of time I get patients with depression, or anxiety, or personality disorders, or substance abuse. And when you take a detailed history, you find that they have history of mania. And history of mania or hypomania is very difficult to establish at times. A lot of time patients is not forthcoming with that information. Patient thinks it's normal, he wants to be that way, it makes him productive, it makes him successful, but it comes with a major cost of dysfunction, which is very hard to realize sometimes. They're sleeping like 3 to 4 hours a day, and they think it's normal. Well, it's not normal, and it causes many problems: impulsivity, grandiose ideas, elation, racing thoughts, distractibility. A lot of times they think this is ADHD, and they try to get treatment for that, and that makes usually the process even worse. And I've seen many times these patients coming into my office with on stimulants, and often this is not what we really want to do. Sometimes it takes many months or not years for the patient to come to the conclusion that yes, I do have this problem and it needs to be done something about it. And I think they often self-medicate. Alcohol is one of the major problems. It's a central nervous system suppressant, and it's abused. The marijuana is often abused. Usually you get these patients when they get very depressed and they're in a depressive or low side of the mood. And that's the time when they really come in. And if you don't take the thorough history, you miss it. Sometimes it is difficult because the presenting problem is totally different. And a Merida problem or something happens at the work, and you realize it that, oh, this is really underlying cyclic mood disorder. And it is sometimes very challenging to treat them because a lot of these folks are given medications such as antidepressants or given benzodiazepine. Oh, you have anxiety, take them. And you find that they create another set of problems with that. So once you identify that thing, you often need to use evidence-based algorithms to treat them. And you usually use the double-blind placebo-controlled trial studies, which really prove that what treatment works for these patients. So many times once you have that, it's a part of being educating the patient and engaging in this treatment process, and which is really the challenge of treating them. And when you provide the right therapy and psychopharmacological treatment, you see the result. Bipolar disorder faces poses a lot of challenges to us, and one of the challenges that its morbidity and mortality is very high. You have about 12 to 20% suicide rate. I'm talking about completed suicide. Often these suicides are called accidents, or they're not called that. And if you really take a detailed family history, you will find there is a genetic component in most of the time, not all the time. And that's really relevant to this, that bipolar disorder is really a very disabling disease. On the caution, I would just say that often I also get people diagnosed with bipolar disorder when they don't have. And one of the problem is that often they have some kind of personality disorder or history of PTSD or abuse or a trauma, which causes intense mood changes. And people get confused that this is bipolar disorder, and they put them on the medication and they really don't do well. And they're still coming in, oh, I'm diagnosed with bipolar, but but then you take a detailed history, you find no evidence of mania, but evidence of all other issues. And so borderline personality disorder or other type of personality disorders are often confused with bipolar. And I just wanted to emphasize that that is easy to treat. You have a very good therapeutic treatment for that, and you don't need to be on medications for that. So often I have to take them off as well to realize it that it's not bipolar disorder.